in Hall A.
Show examples of each. So these are the kinds of eyes that when they have coexisting cataracts, there is a challenge. So the picture on the top right, you can't just do cataract surgery there. So that is a specific set of eyes which need visual rehabilitation, not just through cataract surgery, but through specific interventions such as a type 2 K-Pro or an LVP K-Pro, in some cases some other surgery. So we are not going to talk about that, and the audience is mostly comprehensive ophthalmologists, so that we'll leave out of the discussion. If you look at the other two pictures, the obvious challenges here are how to approach the eye for cataract surgery, how to make enough space so that you can do surgery, where to place your incisions, visualization during surgery, preoperative control of surface factors, postoperative management of the surface, and other related issues. So the questions that arise are when to operate, how to stabilize or optimize the surface and the surrounding ocular surface ecosystem before surgery, how to get the best possible biometry, what should be the surgical technique for such patients, and what are the modifications, if any, in your postoperative management. So first comes the timing of surgery. A simple dictum is never to do cataract surgery in an acutely inflamed eye. So particularly in ocular surface disorders which have an autoimmune or an immune basis to it. So there is mucous membrane pemphigoid, there is vernal keratoconjunctivitis, there is Murren's ulcer. So all these are examples of conditions where you have to make sure that you have achieved a quiet eye for a minimum of 3 to 6 months. So some of these conditions, such as very bad Murren's ulcer, OCP, this means that you would have to give not just topical steroids or topical cyclosporin or tacrolimus. These patients need to be on systemic immunosuppression. So typically your patients with very bad OCP might need something like cyclophosphamide initially, then later on azathioprine or methotrexate. Likewise for very bad Murren's ulcer, VKC. So once you have given good systemic immunosuppression, your eye is quiet, only then think about doing cataract surgery, because if you're going to do cataract surgery in an inflamed eye, the outcomes are not going to be good. Thumb rule, as I said, is at least minimum of 3 months when the eye should be quiet. Obviously you have a visually significant cataract, otherwise why would you operate? But I've put that down because quite a few of these conditions, the patients have some trace posterior subcapsular opacities due to long-term use of steroids or the inflammation itself, which might tempt you to do cataract surgery, but actually that's not much of a problem for the patient. So if you are going to intervene, please make sure that that cataract is actually a cause of morbidity for the patient. Unlike your refractive cataract surgery, that's a different ballgame altogether. Some conditions need preoperative, before cataract surgery, reconstructive surgery for the fornices, the eyelids, the conjunctiva, limbus, or the cornea. So you need to make sure that you do that first and then give an adequate gap again of at least 4 to 6 months before you do cataract surgery. So issues like exposure, entropion, ectropion, lid margin keratinization should be addressed before surgery rather than after surgery. Inflammation controlled, I have already talked about. Lubricants, most of us do give to our dry eye patients in adequate doses. But the surface or cornea surgery should come first, because if you have, say, an SJS patient who has very bad lid margin keratinization, and that is going to cause recurrent corneal problems, punctate keratopathy, corneal epithelial defects, progressive pannus over the cornea. This will also affect your cataract surgery outcomes, because if your incisions don't heal after surgery, that can be a potential source for infection. So a very good modality for eyes with SJS who have had lid margin keratinization is to do a lid margin mucous membrane transplantation. So you can take buccal mucosa or labial mucosa and try to get it to be as thin as possible, and then address the lid margins which are affected. So in the interest of time, I'll try to speed this up. So essentially the surface, it can be done by an ocular surface or corneal surgeon who is interested in doing these surgeries and who is used to doing these surgeries, or you might seek the help of your oculoplastic colleague. Again, they have to be tuned into doing these surgeries. So otherwise the surgery is not very difficult. You just have to excise the keratinized parts, size your recipient bed, accordingly take the oral mucosa slightly oversized by 20 to 30% because it shrinks, and then make sure that you trim it very well. and then suture the anterior part of the graft to the lid margin. The posterior part can just be glued down with fibrin glue. So this surgery, although not difficult, it does take some time and you have to have the mindset for it, but it is very gratifying for the patient. So you can see the mucous membrane grafts which look pink rather than white keratinized surface, and this helps the cornea. The cornea is better, and if you're going to do cataract surgery, the chances are less that you will have surface breakdown after this. Likewise, this is one of my patients who had such a severe dry eye post SJS that you can see she isn't even able to open her eyes in the OPD. And this is an intraoperative photograph I have taken just before doing the surgery. And what we did for this patient is, these are of course extreme conditions and I don't advocate doing this in every patient, but what we did was a minor salivary gland transplant. So what you do again is similar to taking the buccal mucosa for mucous membrane grafts. You take a slightly deeper chunk of tissue from the labial or buccal area. This is, of course, I'm creating space in the eye. So you can create space either in the superior or inferior fornix by cutting the conjunctiva and dissecting the subconjunctival space and making sure you have enough space to put your transplant. And after that, you take the buccal mucosa along with a deeper chunk of salivary gland tissue. And those glands, you need to make sure that the graft gets vascularity from the bed. So you choose a place on the recipient bed where there are good blood vessels and then suture the graft in, and they take up very well. So this is not a magical surgery, but what it does do is it improves the patient comfort. The salivary gland secretions are not as good as the tears, but they help. So your ocular surface staining will improve, the patient comfort will improve, and this will help you to do the cataract surgery better. And post-operatively, you can see that the same cornea, the vessels seem to have regressed a lot, and now it looks like you can at least attempt to do cataract surgery, whether it may be manual, SICS or ECC. So I did an extracapsular cataract extraction for her. She now wears fluid-filled scleral lenses, PROS lenses, and is close to 612 in that eye. So that's a pretty good outcome for that patient. Biometry, most of your cases you will not be able to do optical biometry for these patients. Use an immersion technique for the A-scan. Quite often it's difficult to get keratometry values. If you have access to a good topographer, that might help. If you don't have anything, or even if your topographer is giving you a very poor quality image, that means that your patient has such a poor corneal surface and curvature that sometimes it may be a good idea to defer IOL implantation. You can base it on your post-op refraction or just give the patient scleral lenses. So rather than putting or guessing the IOL power and putting in a random IOL power, you might choose to leave the patient aphakic. Most of these patients will have significant astigmatism due to the surface problems. These are not good candidates for toric IOLs because the astigmatism is not regular, it is very irregular. So if you're doing cataract surgery, your choice of IOL is usually a monofocal IOL. And because there is significant scarring in a lot of corneas, you end up with hyperopic surprises. So it's always a good idea to aim for a little bit of myopia. The surgery itself, most cataract surgeons these days are very accomplished, so there's little for me to say. But choose the technique that you're comfortable with in that particular eye. You need not necessarily do topical phaco for these cases. You can use peribulbar anesthesia if you think the surgery will be prolonged. If you're combining with other surgeries such as releasing adhesions for the symblepharon, doing tarsorrhaphy. Feel free to suture. It's always a good idea to suture your incisions because the epithelium healing takes time and sometimes the incisions don't close that well. Get adequate exposure by releasing conjunctival bands or releasing a tarsorrhaphy that has been done earlier. If you feel that the safest technique in your hands is an extracapsular technique, there's absolutely no problem with that. If you think you want to do SICS, that is fine. But surgeon comfort is paramount, right? During the surgery, you can use HPMC on the surface to improve visibility, use dye to stain your capsule. If you have access, use an endo-illuminator to improve visibility. Try to manipulate the conjunctiva and sclera as little as possible. Suture your wounds, as I said. There may be a case for giving intracameral antibiotics at the end of surgery because there is a slightly higher chance of infection for these patients. If you have opened up a tarsorrhaphy, you might want to do it again at the end of surgery. Post-operatively, now for patients who have inflammatory causes of severe ocular surface disease, as a rule, I do not alter their immunosuppression specifically for doing cataract surgery. So I will not step up their methotrexate or azathioprine, or I will not give them IV methylprednisolone before surgery or during surgery. There is a small subset of patients in which the inflammation might flare up, and those you can tackle using IV or oral steroids. Infection, of course, you need to be vigilant about, so make sure your incisions are well sealed. You stain it post-operatively and see that it is sealed and there's no epithelial breakdown. If you do have punctate keratopathy or epithelial defects, you can use things like bandage contact lenses, scleral lenses, try and minimize the medication which has BAK, or do a tarsorrhaphy to help the surface heal. With these measures, outcomes are pretty good. If you look at reviews of outcomes in SJS, you can see excellent improvement in best corrected visual acuity, as good as 97.5%. Same with OCP. There are published outcomes which are very good. You can see these examples from published papers where people have done surgery in very difficult situations. Same with Murren's ulcer. You might need to do a patch graft, immunosuppress, and then do cataract surgery, but you can get good outcomes. Also in VKC, this is a case report with 25 years of follow-up. Patient had multiple interventions including systemic immunosuppression, amniotic membrane, ultimately cataract surgery, and with scleral lenses has 6/9 vision in both eyes. One of my own patients who is on systemic cyclosporin, patient had corneal ectasia, was a steroid responder, had glaucoma and cataract. We managed to attain good inflammation control pre-operatively. Post-operatively also the patient is on cyclosporin and has excellent visual outcomes with cataract surgery. Do we need perioperative steroids? Not really. Are conjunctival or scleral incisions safe in patients with OCP? Most definitely yes, if the disease is quiet. Do you need systemic antibiotics? No. As I said, you should use a non-toric monofocal IOL. There is no role for NSAIDs. You need preservative-free medication only for those cases which do not tolerate preservatives. So the key message is, there is a unique set of challenges yet, yes, in these patients, but if you have good preoperative optimization of the ocular surface ecosystem, and if you know how to give them good systemic immunomodulatory therapy to achieve quiescence, and you operate on a quiet eye with an appropriate technique, you can achieve excellent outcomes even in these patients. Thank you.